Hello. Yes. Good afternoon, George,
Hi, Anu.
and the entire panel. Michael, Kim, Atul.
Good afternoon.
Yes,
We're
everyone.
just checking that you hear us well because there was some audio issues.
Oh, good. Yeah.
Earlier we could not, but now yes.
Excellent.
Can you see the case number 7 by the side?
Case number 7 on the slide, please. Yes, we can. 74-year-old male. Go ahead.
Yes, 74-year-old male who initially presented with the angina class 3. Risk factor wise, he has hypertension, hyperlipidemia, diabetes, good medical therapy. Cath had shown that he had 2 vessel disease, had distal RCA lesion as well as a very complex LAD diagonal bifurcation with a totally occluded distal LAD. Diabetes, and since it was mid-LAD lesion, he did have a heart team discussion, but he did not want to have any surgery. So the RCA PCI was done, and now he's here for distal LAD total occlusion, CTO. So this is where his LV function, which is normal, right coronary artery, large vessel, stent was done, and you start seeing the distal LAD filling. This is, we have the picture. Actually, you know what? Let me go to the RAO.
Just give us some time to review the loops as they happen. Have the mics up, please. Keep the mics up all the time. Thank you.
Yeah, good.
And this is where you see the bifurcation of the mid-LAD, totally occluded distal. And let me do one more picture.
I mean, clearly this is a very good case for Dr. Puskas, but clearly this patient actually I took care about 4 years ago. At that time, LAD was total. Bifurcation lesion of the LAD diagonal was there, but like 70%, and RCA. So that time there was a discrete lesion in the RCA, and we put one stent about 4 years ago. After the discussion, that patient definitely did not want to go for surgery. He did good actually for the left system unchanged. He came back few weeks ago with the RCA new lesion. The stent was good, distal lesion, so we put one stent. And then now we brought back for this bifurcation complex. So LAD diagonal first, and then there is a CTO. So we felt this is a great case for a no to go get to the complexity. But these are all cases, just want to say, the case which we are presenting, which by guidelines need surgical consultation, all have been. So our goal always is that once we see that case with a multi-vessel disease, diabetic or high syntax score, from our point of view, that patient belongs to surgery. It comes back and we follow those cases. Half of them, they come back after the discussion, but that's okay. That is what the heart team and ultimately is the patient's preference, what they want to do. And this is where this patient was. We didn't ask any consultation this time, but 4 years ago, we had this consultation with this patient. Now, George, you can carry on while we are planning.
Yeah, no, absolutely. This is, first of all, this is a double case. It's a CTO as well as it's a bifurcation. Proximal to the CTO. We get in the CTO, label it as a CTO, we get the bifurcation as a bonus. And Dr. Puskas is going to talk to us a little bit, he's joining us right now, about the possibility of robotic closed chest revascularization of this LAD and diagonal. Would that be an option, John, based on your experience in this case for this patient?
The robotic approach gives us a view through a very limited mini thoracotomy. So we don't see the entire LAD. We are able to bypass a diagonal end LAD when they are in close proximity to each other and typically relatively parallel to each other. I assume that the diagonal you're referring to is the first one there, which is pretty high.
Yep.
And the target on the LAD is in the mid to distal LAD. Those are going to be pretty far apart. Remember, we're looking at a 4-centimeter keyhole incision, so quite honestly, you'd either have to make a bigger than usual mini thoracotomy to graft these two, or treat this as a hybrid approach, graft the distal LED with the IMA, and then stent the proximal LED into that into that diagonal.
So I'm very impressed by the collaterals from the right to the distal LED. The distal LED is not that big. This is a very dominant right that goes all the way to the apex and then also collateralize the LED. So I'm sure that Dr. Kini will open the CTO, but should someone not going to be able to open the CTO, wouldn't that be enough to focus on the proximal bifurcation? Because that's a big territory for diagonals, two diagonals, and just to settle on the mid LED from the prox and then accepting the collaterals from the right.
Okay, very good point, and particularly progression has been in the mid LED. It's a distal LED or mid to distal LED total has been there over 4 years. Oh, how long before we don't know, because that was the first angiogram. So LED this total occlusion is chronic. Progression was in the proximal to mid LED, that bifurcation.
So now going back to how we're going to get our equipment ready for this CTO.
Well,
we have a fine cross here, but anybody want to use a Corsair or a Turnpike, whatever they're comfortable with, anything is okay here. And the first wire, of course, should be a polymer jacketed wire. I like Fielder, whether you're going to have Fielder XT to see if there's any micro channel, that's okay too.
Okay, well, let's see. It's a very challenging case. Let's have to go with the wire first, find the mouth of the occlusion, and then try to do some escalation. There are many branches up top, and then have to navigate through those. And obviously, a microcatheter is a must. Is there any specific from the panel? Is there any specific preferences for microcatheter? Anybody has like a very strong opinion for one versus another microcatheter?
George, we actually just stopped using fine crosses. Caravels have taken over in our lab. They're cheaper and they're
which ones?
The Caravel. They're cheaper and more deliverable. You could also torque it a little. But for CTO, I think you like to use a Corsair because you really want the possibility of torquing through that CTO.
Any other opinion? Nicholson, maybe?
Yeah, I think most of the dedicated CTO community is either using a Turnpike spiral or else a Corsair Pro up front for this. And Caravel is a nice catheter. You just got to be a little careful with it. If you torque it, the tip will break off pretty easily.
So I have a question. Why to open the CTO first and not the proximal LED in diagonal? I mean, this is going to be relatively easy. The CTO, we don't know how long that's going to take. Open the proximal part first and then deal with the CTO.
I think that's exactly what I was just going to say. I think you'd have better visualization and no clot formation from cutting off flow and things. So I think that's.
It's a pretty.
So you show a CTO
because they can. That's why.
Yeah.
What wire is that?
You want to Rota? Yeah.
That's Fielder.
A regular Fielder.
Right. Like a fielder.
Yes.
I think the backup here is extremely important.
Gaia next to us there.
I think we do Rota. Yeah. Rota or orbital? Rota.
So let's see how the microcatheter is going to follow. It has a little difficulty, but it does follow. It crossed maybe 2/3 of it. Let's see if it goes all the way.
So is it possible?
That is what everybody's saying, that maybe Caravel or Corsair may be a better choice in these kind of cases. But we got so used to the fine cross that becomes our workhorse, this delivery over the wire system. But yes, this is the kind of case probably would have been a little less difficult with a Caravel or Corsair. Yeah. You want to see?
Yeah, Turnpike, teleport. There are several catheters available, and like we mentioned, whatever you are comfortable with. I think a Rotawire may go now, right?
Yeah, Rotawire will go. Yeah. Okay, let's get the Rotawire. Yeah.
What size bird though?
First one is 1.25, approximately 1.75 later.
You don't want to try. You don't want to try. Why don't you try with the Corsair to see if it goes? So since everybody mentioned that the Corsair is superior, if it goes.
Have to do Rota. No, I know, but only question is you still have to do Rota here anyway.
But
right? I mean, with this so much calcium proximally, severe calcium. Yeah.
They're saying to cross.
No, don't worry about the crossing. I can tell you, leave this there, take the wire, Rota wire will go in now. Because it has created that channel.
Where's the Rota wire? Floppy, Rota floppy.
Yeah.
What's in a rather
See that calcium.
in a rather straight segment here?
Calcium.
What's your preferences for Rota floppy versus a regular Rota wire? In this particular case, I know in general it's
access
Rota
support.
floppy. Here could be both,
No. This definitely.
Could be any, yeah.
George, we've
In this case,
tried
could be
this
any,
new
yeah.
Rota drive wire, and we found it to be, I like it more than the Rota floppy. It doesn't bend as much. You could actually free wire it a little better than this floppy. So I think it's like $10 more, unfortunately. So that always, the administrators go nuts over $10. But
That's it. Here goes our coffee.
That's right.
But yeah, Rota drives a new version of both floppy and extra support. They are more one-to-one torque and good, I would say, device, good wire, some improvement. At the same time, only issue remain in some tough cases. We actually have couple where it did not give enough support. But I think it all happens at how much you have used. We have done some cases, maybe 5, 10. So far, it is just getting some more experience. Once you get experience, then I'm sure this all will get better. But yeah, Rota Drive is a new addition to their armamentarium, particularly that you could do a final advancing and so. See that? Your nose, just to teach everybody, once you brought your catheter, nose of the catheter into the lesion, you can leave there, take the wire out and put your Rota wire will go almost every time. Maybe 1 in 1,000 would not, but otherwise will go in every case.
Very good.
Was there any thought of just ballooning there and see what your initial balloon did? I mean, the crossing balloons are so good nowadays. It's not usually a heavily calcified area in the LAD.
No, it is heavily calcified. Look at that. That's why we did the fluoro. Look at how heavily calcified it is.
Go back, show them.
Yeah. See this, here. Tram track, entire vessel. So yes, I mean, this will be the case.
1.5,
I would
right?
say could do okay.
1.25.
But as shown by the Rota regret, about 24% time, you'll be in trouble that not able to do it. And now you want to do a bailout, which is one approach. But otherwise, you just go ahead and go with that strategy. Yeah.
2.5 to 7.5. Yeah, 2.5, 2.520.
2.520. Yeah. So we have 1.25. Our principle is very simple. If you could not get your fine cross delivered, or very difficult actually, even if went, but very difficult, go to 1.25. We need a 1.75 proximally anyway. Such a calcific vessel, as you see the proximal. So we need a 2-bar approach. This is the case. Overall, step bar, George, as you know, done in less than 10% of cases. The cases which come to us, 2-3% of the cases we use 3 bars. But this is the 2-case bar. Yeah.
Right. Now, I mean, very clear, because for the CTO, you need a small burr to do a good job proximally, and the bifurcation that everybody was so interested in, and potentially even protect the side branch, you need a little bit of a bigger burr.
And we actually have a 7 French guide. If need to be, we can use a 2-0 bar proximally.
Yeah. So you go 125, 175?
Yeah.
wow.
Yeah.
No, I would say if we are not going to the lesion,
I think we have to.
Okay
So
to go to
what we'll do is, once we have it, we'll dyna all the way down there. Okay? Good.
Just why not burring? Yeah. We need to burr anyhow.
Or start.
Okay.
You have to pull back the wire a little bit.
Yeah, great. Can we, while we see the burr happening, can we talk a little bit about pharmacology during a rotablator case such as this one? Well, obviously, this patient had a previous PCI, so it's preloaded with P2Y12 inhibitor. Dr. Sharma, which one you use? Ticagrelor in this case?
Yeah, so actually what happened is last time he presented 3-4 weeks ago with acute syndrome. He used to be on clopidogrel. I gave prasugrel last time because acute syndrome. So he's on prasugrel and he's on bivalodin.
Okay.
Yeah, I know a lot of people are worried about using bivalodin in a CTO, but in our lab we routinely use it. Although bivalodin used now in our lab is about 60%, because most of the radial cases we continue heparin, and some cases we do worry about giving the bivalodin, but like this is kind of case where if somebody wants to do it on heparin, nothing wrong in that. But we have seen that wire perforation do very well with the bivalvular compared to heparin. But yes, CTO area remains questionable. People say, well, it is very expensive. I know that at one point bivalvular used to be expensive, then became generic. The cost became 1/3, but yeah, still definitely a little more expensive than heparin. But most of the time we have seen that it definitely caused less bleeding overall. And that is the reason for us to use bivalvular compared to heparin. I know many of the labs in the country or globally have shifted to heparin only.
Yeah.
Maybe
George, can we go to some wire escalation? I know we never had a chance to wire escalate here. We just crossed the CTO.
Well,
what should be the wires if you are going to wire escalate?
I think the difficulty, I mean, the plus and the minus of this case, the plus of this case is that it was rather straight. Once you negotiate all these complex branches up top, finally you get into a funnel. Well, with support from the microcatheter, the wire essentially had to go straight. So that was a plus. In many ways, also perhaps more of the calcium was earlier than later. So there was a very good, great choice, and it worked out. If not, you have to go with the another alternative might be to start with a pilot 200 and then escalate to the Gaia family, etc. For example. But let me ask something different. I see Dr. Freeman and Dr. Kukar and then Dr. Tamis. We're just hearing of standalone cath labs, potentially not in hospital, and performing rotablator cases. Very soon coming up, apparently, in some areas of the United States. How would you feel performing a procedure such as this one in a standalone cath lab? Dr. Kukar first, and then Dr. Freeman, and then Dr. Tamis or anybody else, please. Just very briefly.
And let them answer it, then I'll answer the final one on this field.
In the state of New York, CTOs in a lab without surgical backups are not allowed. So if you have a planned CTO, it's not the appropriate thing to do. The bifurcation is a different story. I will let Jason comment on the Rota because he does them at his lab and does not have backup. But when we're planning a lab at Mount Sinai, Queens, we will not be planning to do the CTOs there. And for the right reasons, I think if you have a complication, you don't have the full support, not only of the CT surgery, but the full support of a fellow and multiple attendings there to help you bail you out.
Yeah, just to piggyback on that, CTOs.
Let's focus on the rotablator.
Yeah.
Forget about the CTO.
I think if you're comfortable and you've been an experienced rotablator operator, I think you know which cases not to try, without surgical backup. I think the bifurcation is definitely doable in a non-surgical on-site center. The CTO would definitely preclude you from doing this case, even though it's a short, straight segment, and that's why the wire went across so easily with the fine cross. But this would not be the patient that you would do offsite.
Jackie? No, for Tamis.
Is it go?
Yeah, go ahead.
Okay, thanks. So I think that a lot of the concerns nowadays with the rotational atherectomy are no longer going to surgery. They're easily fixed with the covered stents, et cetera. I think the issue is more logistically, sort of like Artie said, which is really you're at a lab with not a couple of attendings available to help out. Somebody's putting the impellet in while somebody else is doing the covered stent. So I think it's more a logistical issue in terms of having the support you need from a nursing and an attending standpoint.
Just to complicate things better, over here we have a step burr approach with a 2-0 burr, I think. Dr. Sharma, you have any comments?
It's a 2-0 burr right now.
Talk to us about the burr choice.
Yep.
Go ahead.
George, just to finish out with the surgery backup, we do a lot of Rota. We had surgery backup.
So question. So just to say, so as you see that usually we say don't jump more than 0.5, but goal was 1.25 was for the distal, not for the mid. Mid is a short lesion, so going with a 2 bar is reasonable because heavily calcified vessel. And that's what going through the regular process of slow advancement.
Yeah.
Now we need a little speed up. Go to about 140. Yeah, it's about 130. You need to go to between 140 and 150. Yeah.
George, I will say, this new Rota Pro system and this is a good example. I see a lot more D cells than the legacy system.
Yeah.
You have to go up higher RPMs. We used to go like 140 safely. Now you have to go at least 160 because a D cell is a lot more for whatever reason.
So it decells
just
more if you go 140 or doesn't burn? That doesn't go through, you mean, or it decells at 140 but doesn't decel at 160? I'm not sure what.
You might decel from 160 to
Stuck in the
135, but if you go to
Stuck in the
140,
guide,
you
I
might
think.
just stall.
Probably.
Oh, I see
okay,
what you're saying.
come out.
I haven't seen that. But,
Yeah, basically, as the point is,
individual
there are two
experience.
reasons. One is the resistance in the current Rota Pro system is so low, the deceleration is much faster, that you mentioned compared to legacy system. So I have to be careful, and we know that in the beginning, while they were making some changes, we were having a higher Rota burst stuck because there is no resistance, and RPM goes down. Now coming back to the Rota, this goes back to in 2014, 2015. I was in the New York State Department of Health Advisory Board. That time the request came that can you do rotablation in the standalone cath labs? And we voted. And we barely by one margin, we won that yes, in appropriate case, with the not have a LV dysfunction and so, the Rota can be done in standalone cath lab. And with that note, as you know, at present, we do a standalone rotablation at BI, and then we started at South NASA. Now we started with Duvuri line at Staten Island. I personally have started Rota at many of these centers with a standalone and have been a good success. Key is, yes, you select your cases. You don't want to have a case with a bad LV, left mid bifurcation, and so standalone at present is allowed in New York State, and they leave it to you what you are comfortable with. They don't have any guidelines. People do ask me that what are the guidelines for the state? They say just leave it, but yes, you can do atherectomy. Only 2 years ago, they changed that you cannot use Impella in elective cases. At present, only in cardiogenic shock in the standalone cath lab. And secondly, you cannot do a balloon aortic valvuloplasty. Those are the two changes happen. And Jackie is on the advisory committee now, and she can comment on. I still couldn't understand why they will stop doing the balloon aortic valvuloplasty. They stop for the standalone cath labs. I know the right-sided ablation. That has been a no-no for a long time for the EP point of view. Left-sided ablation. But the key is still the state requirement that you cannot do balloon valvuloplasty in a standalone cath lab is a little not clear in my opinion why that rule was changed.
Yeah, I don't know if I was there for the conversation regarding the balloon valvuloplasty. I don't recall being there, but I think the discussion about the Impella assisted PCI was that if it was really that high risk of PCI, that it was better done at a center with surgical backup.
Great.
That goes just to reemphasize what Samin said. It's really LV function that really drives this thing when you don't have for cath labs.
So you don't want to have a very depressed LV function in these cases. I knew what kind of balloon size and type you use for this exercise.
We used a 2520 balloon. For the distal LAD was a 2520 balloon, and this is typical in a CTO. Once you balloon it, there could be little thrombus in that CTO, no matter how old the CTO is. That's why we have some flow abnormality. I think we give some vasodilator. We'll put one stent across. What do you want? 275, 32. Or what else we are going to do? 32, 38, 275. 32.
AK, can you comment on how you're taking the stent size when you
sounds like you need a 38.
The vessel will be?
You want a 38? It's you see that the LAD is bridge also.
Do you want to IVIS it?
Are you able to recognize the bridge in the LAD?
Well, we have to, but the bridge goes at the end of the CTO. Okay. I don't think there's a way to avoid that.
Okay, no, we will. So you want to put us a long one?
Well, you have to think about the surgeon. He may need to come and graft it one day, so maybe you don't want to put the stent.
Yes, that is why I didn't want to put a long stent. Exactly. Let's go back.
Well, although Dr. Puskas can talk to us about stentectomy, if it's stented and then needs to be bypassed. Isn't that right, Dr. Puskas? It can be a stentectomy, facilitated bypass can be done.
It can be done. And we have done a couple handfuls. But
Very
we
good.
prefer not to. It's a high stakes endarterectomy.
32,
And,
right?
that plane
32.
will be developed between the adventitious.
What was
and the,
decided
for
here?
endarterectomy.
Science or
That is
promus?
Sometimes very, very fibrose.
So it's a synergy now?
It's very
because you put
difficult to
biosynergy
raise
on
a
our
small
Okay.
plane to do the stentectomy.
That's it.
That said, it's not always impossible, and we've succeeded a few times, typically in full metal jacket LEDs with relentless angina.
This could be a good indication for drug-coated balloon. We talked before at lunch with Antonio about
So what do you
where
want to prox LED?
use
3.5?
PCBs. This could be a great
3.5 high
function.
pressure.
We don't have it approved in
3.5,
US, but
15?
there
Yeah,
is.
good.
That's what we said.
So let's go ahead with the CTO so we can then talk about how to tackle this 0-1-1 bifurcation and talk a little bit about the bifurcate ad to help us decide on what next step is going to be. Let's get the panel start thinking about that. One lesion ahead.
Someday.
It's a good point to remove the body wire before you deploy the stent. Don't forget that.
You know, George, in terms of the standalone cath lab, I do think that the shock wave is going to have a big role instead of possibly Rota in these places. I think, that may be.
Yeah, probably true.
Up again. Get on.
I think that's a good point. I think one of the things we were fortunate at BI to have is we had surgery and had a trained cath lab. So it's really about your techs and your nursing staff. So anything that is the easiest on the staff and it's
Want to dilate the proximal part of the LED, right?
All right.
I think some vasodilator will take care of the distal flow, right? So we will now. How do you guys want to handle the bifurcation? I'm going to wire the diag.
Why don't you take a 3O balloon, high pressure in the stent, and then predilate this proximal lesion as well? What do you think about that? Not excited.
Okay, we have a 3.5 actually. We have a 3.5 for the proximal LED.
But don't you want to wire the diagonal?
Yeah, we need to. We will wire the diagonal. But you're saying post-dilate the proximal part of this distal stent?
Yeah, I think so. I want to make it a little bit bigger, no?
Yeah, we need to post-dilate that. But
We
that
kind
should
of
be
need to,
3.0.
yeah. I know. Anu wants to finish the case
So we are
fast,
going to
but she
wire
also
the
realizes we kind of have to do it.
Yeah, I would massage the distal segment of the stent. It looks to me like either spasm or pinch there or plaque shift. So gentle, just go.
That's great. So let's pass the wire first into the diagonal in order to be ready for the further action in towards that vessel. And there is a question always that comes up: is there a reason to put a maybe cut the ostium of the diagonal in some ways or pathways, and before the stent or not, because it's a tight calcific lesion, very ostial there.
So they want distal massage followed by. So we'll cut the side branch.
Leave it alone. It looks like the disease
Which one?
is a little bit away from the ostium. And just maybe get another angle and just verify that and just try to make this a little bit more simple in the proximal LAD.
Avoid the diag, you mean?
No, it's a conference for complex cases, but
Yeah, well, it's a complex case. It's not a CTO, it's not a bifurcation, it's both. That's what a complex case is.
agreed.
Okay, go here. 4 atmosphere.
Let's do a little.
Gentle massage at the bottom.
Be a little careful. Yeah, I think let's finish it. Short massage.
Yes.
Yeah, only 2 atmosphere.
Yes, 4 atmosphere.
Out, down.
Good, down. We call little psychotherapy there. And then we go high pressure at the proximal edge here.
Yeah, that's right.
Good. Yeah, 18, 20. Yeah, good.
Great.
Down. Now, important decision here. Are we going to do 2-stent strategy or cut and stent across?
Well, you can try with one stent and
fine.
do, but I think you'll need to still balloon the ostium of the diagonal. It looks like tight.
Yeah.
And then make a decision
based
whether
on,
you leave it provisional or the 2 stents approach.
Based on the criteria and what the app says is that the side branch has significant lesion and the vessel size is close to 2.5, which means we need a dedicated 2-stent strategy here.
Yeah, it's probably more than 2.5.
Let's ask the panel, what would they do? A 2-stent strategy or balloon and stent across?
Well, that's real quick. Balloon. Forget the diagonal or treat the diagonal? Jackie.
Yeah, I'd cut the diagonal and then stent across it.
Okay, cut and stand across. Michael.
I like that strategy.
Same. Nichols.
I'd obviously see whether or not it's involving the ostium of the diag. I don't think it is, and then I would just do this two separate.
Thank you, William. John.
I would balloon the LAD first, see what happens to the ostium of the diagonal. Again, I don't think it's fully involved, and I would try to avoid it and not touch it at all.
Jason?
16, 18, 20.
Matu?
I'd cut the diag and stent across.
So the majority is we cut the diagonal, and the strong minority position that include Dr. Fox and Dr. Kini, apparently, ballooning the LAD and seeing what happens with the diagonal. So let's see about that.
Okay, down. So there is you see a chunk of calcium on the lower surface there. Okay, let's see what how the diagonal looks. Definitely it'll look worse. So we will have to do a cutting balloon right now. Yeah, flow is.
Yeah. So
okay, get us, what's the cutting balloon we have? 2.5. Yeah, 2.5 cutter.
The difficulty sometimes when you dilate over the LED, you shift the plaque a little bit.
And what's the size to
pass equipment into the diagonal, particularly calcific. But let's see about that.
Too long,
256 cutting balloon. Is that a 4 cutting balloon, by the way?
24.
We keep making them smaller and shorter and shorter.
Okay,
we don't need more than 2 millimeters here, but
I think that strategy kind of makes the decision.
This came out
in that sense.
Okay. Well,
this is bigger than 2.5.
Let's make this case even more complicated. Recrossing with the wire.
No.
As long as you don't do decay cross.
Now we are going to the side branch. We are using a cutting balloon, Wolverine 2.5 to the diagonal.
Okay, let's go for it. Let's go for that. Rota in the main vessel, cut in the side branch. Let's see how that goes.
Okay, here.
Delivery, very good. Despite the plaque shift that I was a little concerned about, no issues. All right, how high want to go with this balloon? 10? 6.
Yeah, we went to 14. Down.
No, let's go 10 first and we'll see about that.
Okay, go up here. Yes. So we are making sure the ostium is cut. Nice. Okay, down. So this is the moment of truth to see. Ready? Go.
There you go. That was an old-time classic cutting balloon of the ostium of the diagonal. Dr. Colombo, we have a guest star comment. You come up here with me. Come next to me. Come next to me, Dr. Colombo, over here. I have a guest star here in the moderator.
Just one
Antonio.
comment. You know, when you see this eccentric calcium on the LAD, which is a pain in the neck, it's very difficult to handle. You place a 1.5 balloon in the LAD, and then with the balloon inflated at low pressure, 6, 7, you rotablate with a 1.5 burr.
You rotablate the balloon also?
Yes, and the balloon will not break because it's soft and will create bias of the burr.
You mean not inflated balloon?
Inflated. And will push the burr toward the calcium and bias and cut the calcium.
So it makes it even more directional. It's a directional, intended to be directional.
Exactly. It's a directional, rotational attack.
All right, we'll try another off-label technique soon. Coming up.
I warn you, don't try it at home.
Okay, yeah. Don't try it at home and don't try it in New York and USA. Okay, now what do we do here, guys?
All right, looks good. What do you want to do now? What does the app say? Forget about what we're going to do. What does the app say? Dr. Kini.
No, based on the based on the app, this will be two-strand technique since there's a significant lesion in the diagonal and the length of the lesion was just about 10 millimeters.
So we have a
Because
terrific
you
result,
cannot have.
and you don't want to follow the app.
But the result could be changed
Okay,
after the
then we'll
standard
send across.
LED.
You don't want to follow the
Yeah.
app. You're inclined to revise the app, maybe.
No, I would
There
follow
will
the
be
app and
addendum.
put 2 stents. But if you guys want to stent across, we're okay.
I mean,
I'm
if you
ready
want to put
to
2
show the
stand, you
technique of
can,
recrossing also.
you can, I don't know, try. The question is, if you put 1 stent, because of this eccentric calcium, can you really gonna expand it to 375 or something? Or it's gonna create a bump in that? And should you just put a V stent, not trying to make the distal, the distal main vessel match the proximal main vessel? Leave alone proximal main vessel.
375 cutters or 4.
What do you think?
Yeah.
I think it's a 4.
No, we are planning, since that eccentric calcium is there, we want to cut that area with the 375 cutter.
375 cutter. All right.
Right there. Yeah. And then I think we will stent across.
Yeah, well, I mean, standing across means that you have to match the stent to a very large diameter of the proximal vessel. That's what I was considering about. If you compare to that little bump, maybe more than you think. Whereas if you focus on the distal vessel, that's not so bad. Dr. Waxman has a comment.
No, I think the app is right. I mean, look how many procedures you have to do, and you still may have to put another stent. So you're doing cutting balloon 1, cutting balloon 2, then you're going to put the stent, and you have to do post-dilation. You know, isn't that simple to go directly with 2-stent approach?
Yeah, well,
when you have an ostial diagonal of a big diagonal, this one is maybe more than 2.5.
Yes.
It is
So
definitely.
I think the app is right. You can go around it, and then you may go back to the app, but I wouldn't change the app.
Don't change the app. Let's avoid a disaster. That's what we have to do.
No. Okay, then let's follow the app, and we selected 4028 for the LED and the 25.
You don't want to inflate
16 for the side branch.
Put a little bit more proximal and inflate
What?
this thing. Yeah.
No, I am doing that.
Okay,
Look
great,
here.
great.
This
That's
is
a
exactly
really
where that
big
eccentric calcium is.
That's a really
Yeah,
key
we
one.
are about 16 atmosphere. Look here.
Yeah.
I think we
Really
did
go.
something.
Keep it up. Dr. Tierstein's idea sometimes you have to keep the balloon up for 45 seconds in order to have effect of this of the pressure. So
Okay,
keep
done. Okay, get the 2 stents.
45
Okay,
seconds.
well,
in California.
mini crush
New York is
technique
20
of
seconds.
non-left main. Can we start playing the mini crush technique of non-left main by the side? App team.
You want to do mini crush? You don't want to do V?
No.
You want to do T? You want to try to do T?
This is not a V. No V. You want to cover the LED fully.
Oh, let's see.
Also, if at all the patient comes back, then recrossing in a V is very hard. Recrossing of the side branch in a V, recrossing of the side branch in a tap technique is very hard.
Very difficult, indeed. Very difficult to disaster sometimes, particularly if you crisscross in the wrong way and you put a balloon and then you crush the stents even.
This is a lot of crisscrosses here.
But we continue to make this case extremely complicated by requiring Dr. Kini to keep recrossing into the side branch through lumen.
I know. You know why? The patient has a lot of tortuosity, groin tortuosity. Every wiring, everything is very hard here. Yeah. Okay, give me the stents quickly. 2.5.
Is a 4.
All right, we have 21 minutes
Okay,
to the end of
2.5.16.
this transmission. And Dr. Sharma has slowly made his way to the next room for case number 8, I presume. But we continue to stay here to see the double stent technique, exactly as the app planned and suggested.
Is the app playing by the side?
No, nothing playing. Let's play up the app, please. You got to show the app in the factoid screen, on the side screen. Oh, yes, we does see it. Yes, that's right. Keep playing that, though. Keep looping it. We see the 3D app. Yep, that's right. The 3D app is shown. Excellent.
If only it really was like.
So we are going to the side branch.
Okay,
Good.
let's see.
And now main vessel.
That's great.
4028 in the main vessel.
All right.
So then what we'll do is we'll deploy the side branch stand.
That's a bit generous.
A millimeter of the...
lengthwise. 28, yep. Definitely can't miss.
I think there's a kink in the guide or any tortuosity difficult for the stand to go, right?
It's the effect of the 4-0 stand. That's no matter how you cut it. It's a big stand.
Yeah.
Why don't you go with a 3.5 and then you are post-dilated anyhow?
Shorter?
Yeah, 23, maybe.
3.5, 24?
Yeah, 5.24, yeah.
One other approach is
we can do a step crush. The other thing what we can do is do a step
Dr.
crush.
Waxman was to further complicate this case. It wasn't complicated enough for him. So he says, forget what we're doing right now. Let's start doing physiologic assessment of both lesions to decide what's happening. What do you think about that?
No, that's not what I said. I suggest you make it even more complicated than what I said.
Of course I am.
He wanted to put me in trouble. No, I was just suggesting to do it for the
giving
diagonal. If it's good enough, then you save a stand there.
3.5, 20. Yeah.
I know. Everybody
No, I think we can do step
the up
crush.
down, but the up is going
You are
to
3.5?
Two-stand technique.
Yeah. You are 3.5, 15, something you had, right?
Two-stand technique.
So instead of mini crush, we are going to show step crush. We are going to put a balloon in the LED, crush it.
That's
then
right.
put the stent in the LED, recross.
So-called step crush.
Avoiding the multiple steps of the decay crush. Yeah. So multiple steps of the decay crush, we are cutting short.
Okay, very good. So the technique here is maintaining the same stand in the diagonal. And instead of putting a stand in the LED, we're going to put a balloon in the LED. And after deploying the diagonal stand at the ostium, the balloon in the LED is going to, and removing the balloon of the stand, the balloon of the LED will be crushing the just the first or second strut of the diagonal stand against the wall.
Even this is not going.
And then the LED stand will be subsequently introduced into the vessel at another step of this.
Get me a new balloon.
I don't know which one more complex here, the CTO part or the bifurcation part. I think the bifurcation part is more complex.
Yeah, you know why? There is the tortuosity, and maybe now there's a kink in the guide. I cannot get any device up. So we're going to go to a non-inflated balloon. CTO was very fast.
Why don't you put just a
this is taking
compliant
us now,
balloon
but
there.
that's okay.
Just put a compliant balloon and inflate that. That's got to have to go. Yeah. I mean, the only job of this balloon is to just deform the first or second strut of that stand. There is no other function. So you're not really inflating it to break a plaque or anything. So even a compliant balloon is gonna do that job to deflect the stand. Exactly.
So now you see there, we want a side branch stand come into the main some die.
All right, great. Let's do a little test.
A millimeter, a little bit of the strut in the LED. Everybody okay?
Perfect. Right there and there.
Inject.
Don't move it.
Good. Go up with the side.
Even
stand. We're going up with the stand.
They're going to go with the stand at a high atmosphere.
Good. 14. Yeah, we are 14.
You saw the indentation on the balloon of the stand, which was demonstrated there was residual stenosis there.
And now you've got to come a little bit back and go even higher to make sure that the ostium is good. And now you are remove the equipment from the.
This is not in the George. This is not in the app. Okay, down.
No. This is.
So now we take
app.
the wire of the side branch.
That's in the new app that haven't gotten yet. That's in the app 2022.
Okay, right. So now I'm going to take this wire out.
Very important.
Okay, crush that. Yeah, go up.
Why don't you just do like a
crush?
Go crazy.
Good.
Exactly.
Good.
Very high pressure. You really need to put that strut up all the way. Doing small inflations there is not going to serve the purpose because you know you may not crush it, and if it's sticking out, you're not going to be able to pass your stent in the LAD, which is going to be a big size, therefore it's going to be a bulky device, and all the stories. And of course, Dr. Kini is going to have to recross this
not yet.
diagonal.
Right now, remember, for the DK crush, we have to recross, we have to kiss. We are not doing that step. Instead, I'll place the stent in the LAD, recross, and then kiss.
I know, I understand, but I'm saying
So that is the
very
difference.
you're very ready. You have recrossed this diagonal, if not 5, for sure 4 times already. So it's going to definitely happen even with a crush stent in front of it. Let's see. We keep making this case even more complicated with every time. It's really a great case. Really a great case.
Any other techniques?
No,
So
no,
now
I
we
think-
are going, this is the same 28 or? Yeah.
So the only thing, as you can say here, let me explain that unless the stent strut is crushed, the stent that we're trying to place now may not go because
you can
it may
see it's
bump
crushed.
on that strut. So it's very important.
Can
for
you see the
strut,
crushed stent?
and you can see it very clearly, and therefore the pathway to the LAD is open, and the stent goes in very easily.
Some die.
And
Good now?
Oh, it's very good.
Some
It was
die
very
there.
good.
Yeah.
Advance a little bit, huh?
Okay, good.
Yeah, it was good at the beginning.
I think that's what we want.
Just end it up in a natural position. Let's go. Excellent. Excellent. Exactly
Okay, go.
where you want it. It's exactly
Okay.
20 millimeters. 24.
This is a 4-0.
At least.
Now you see, it has crushed it.
At
Good.
least.
And now we will recross. Okay, down.
All right. Now is a difficult part.
So one question, at this point, do you
Tricky
do a
part.
pot or you just pass the wire to the diagonal and the pot after that? Or you do pot
I
now?
would, I mean, the pot, yeah, pot is essential for
Why don't
left
we do
main.
Why don't we do a little pot now?
Not.
Well, you have the balloon, the wire ready. You want to try it with a wire because the wire is right there. But you can do
I'm
a
going
pot.
to try the wiring first.
Yeah.
The pot helps you sometimes to rewire because
true,
they give you
it's
a
true.
bigger lumen.
Yeah.
That's why they advise to do the pot now.
It's true. You may want to, well, you know, if you want a pot, pot may also be 4 or 5.
That, that point is very important.
Very big.
If I have trouble in wiring, then of course we'll pot. Otherwise, we will.
Pot or not to pot? This is the question. There you go. It went in already, but it can't follow.
Yeah, I know.
I mean, this is this wire has
This is the
crossed
same
about 4
feeder
times already.
wire.
Can't you get a new wire there at least? a little new wire as opposed to this banged up 6 times wire.
Okay, get us a new feeder.
Yeah, a little bit. Yeah, please get a new
It
wire.
has a little memory. Even if I say don't go, it is trying to go there.
Yeah,
See?
yeah, right there. It went. Of course, as soon as you ask for a new wire, that's when it's going to go. That's the trick. You have to say the magic words that this open a new wire. Then it
What's the
goes.
size?
Hasn't
Okay.
anybody noticed that? It happens all the time. But you have to really believe in those words when you say them. Otherwise, it doesn't work. If you fake it, then it's not crossing.
And the nice thing is, you cross the side branch stent really towards the distal end of it instead of up top, which really helps get a balloon across.
All right, now let's go. What balloon is this one? It went very, very good. 2.5?
212. 212.
2.0. Very good. Excellent.
212. Yeah. What we'll do is we'll create a little channel. Then we'll go with 2.5 high pressure balloon,
Yeah.
a 4.0 balloon to the LED, kiss, and that's it. Then we are done. So the various technique, I think exactly what Ron Waxman mentioned is that if my wiring was difficult, then yes, pot, especially the large vessel, there was calcium, the likelihood you can go behind the stent strut. That is why you have to do proximal optimization and then cross. Very important, proximal optimization in left
Excellent.
main.
Excellent.
Okay, apparently they're ready in some other room. So what I'm going to do here is a final kiss, and then
Yeah, I
will be
think
done
we
here.
completed,
You guys
we
want to move to
completed
the other
all
room?
the steps, and let's thank Dr.
Yes.
Kini and Dr. Parasuram, who are doing a great job over there in this room with a CTO, reverse crash, and all these things after.
Let's show you the final picture before you leave. All we have to do is kiss now, but let's show you a
Let's see
final picture.
one injection. We see the distal vessel, how it looks now after all the.
Yes, yes.
Because it could have been open
It's going to
even
look
better.
fantastic. That's how it's going to look. Indeed,
Yeah,
it's
you
fantastic.
see nice distal LED. I think
Fantastic.
with vasodilators, it will get better.
Fantastic. You want to do
Yeah,
a
little
kiss?
bit nitro will help.
You want
to
to do
the
a
distal vessel.
high pressure kissing balloon, and then the flow is going to get
Yes,
better.
2 of 50,
Things
huh?
going to look great. Let's go to another room now. Well, are we ready
No,
in the
no.
other room? Yes, we are.
Okay, we continue here.
Okay, let's.
Okay.
We're already connected with Dr. Sharma and Dr. Barman, as I see in that room.
Yes. Okay, the only thing is little case change. This is a case number 9.
Case number
Not
9.
8.
All right, very
9.
well.
See-
We're going to go. Can we see, please, the factoid of case
Side
number
the
9?
Case number 9.
Case number 9, 69-year-old male. Can we see that
Yes.
slide, please, on the side? Okay, go ahead, Dr. Sharma.
Yeah, and as you mentioned, this was a double. Yeah, this was a double case. With Anu did a beautiful bifurcation with CTO. So what we'll do, I know we are rushing to time. We want to be on time, just like entire morning, and we'll just present the case. You start the main lecture by Dr. Colombo and further discussion, all lectures you have, and we just will continue on the side. So with that note, as you can see here, this case number 9 is the patient 69-year-old, angina, dyspnea, and patient has multiple risk factors shown there, and has an inferior wall ischemia, had an intervention of the RCA in the past, and now has a totally occluded RCA which fills by collaterals. It was a synergy DES, and we see they started with a radial loop and anomalous origin. It's anterior takeoff and try to navigate with a different balloon and so. I mean, first the guide catheter, then we'll get into the wire and so. So we want to show while
So
we
it's
go.
a CTO, but here we're talking about now an RCA CTO, distal RCA CTO, instant restenosis. Let's take a look at this lesion. And what some trouble going up with a radial, I can see, but let's just navigate in the interest of time.
Okay, sure.
So see there, it's a RC, distal RCA. Total our plan here, as shown there, is that once we clear, of course, you need 2 injections because the loops and multiple stents in that RCA you can see. Totally occluded, but good collaterals, which you can see here.
Not only that, the
will-
RCA has an ectopic takeoff, and the guide doesn't provide enough support. You have to try to go guide extension and all that. So it's also a very complicated case. It's not just a CTO. It's a proper guide selection case as well.
Maybe
In
try
this
an
case,
implant
our page will be the laser with eczema, ALCA. That's our plan. Or this totally occluded. We'll try to do the laser. This is what guide is this?
This is a VL3. It was sitting.
It's a VL30. From the groin, we were able to fit it last time very nicely. But again, these are the very challenging from the guide point of view, and will continue to work. So, George, in interest of time, you saw the beautiful demonstration of room 1 by
Absolutely.
Kini.
And as we said, before, he may a guide extension may be useful here to have a secure
We have it
position.
already
We're going to be
ready.
looking at it on the side. Let me ask Dr. Sharma if we should go on a 10-minute break, or he just wants us to show the final result of his great result we see and then go to a break. Dr. Sharma.
Fantastic. George, okay, we'll tell you where we left. Okay.
We left with no guide.
The guide was very troublesome. Keep going. As pointed out, we need a guide liner, Godzilla, able to get very difficult. This is the Corsair. Finally, we were able to get through. And then this is the laser. Laser with the 40, 60, 80, 80, even later on with the contrast would not go through. So somehow there was a calcific nodule, which was continues to give us a trouble. And we needed then the Grand Slam wire to give us that support. Finally popped up. And then we were able to do the intervention. As you can see here, we have put 1 stent. See, I'm now going with the laser, with the contrast.
Right here.
Yeah. Right there. Look at that.
Even after bringing the Godzilla down there, we couldn't pass that junction right before the AV continuation.
Good.
Ultimately did, yeah.
Yep. And now we put one stand post-dilated. Let's show you the last picture. And we are done, and you can go on your break and get the next case ready. This is where we are now. And we'll
Okay, tremendous. Congratulations. It was a tremendous.